At Stanford Health Policy, we also study domestic policy questions very broadly. Questions like, how does health and law intersect? How can law and regulatory policy be used to improve health? How does the Affordable Care Act affect health outcomes, costs, and quality in the United States? How do we understand what high-value health care is? Can we do things to help reduce health care costs?
With my first hat, I'm a primary care provider and medical director of care for children with serious chronic illnesses in our community, where I work with other members of the Departments of Pediatrics and Medicine here at Stanford to provide the best possible care that we can. With my second hat, I'm a health services researcher. We find that even in a specialized program like CCS that's already taking care of kids with serious chronic illness, within that population of roughly 200,000 children, 10% of those children are responsible for more than 70% of health system costs. That's really an extraordinary skewing of costs that we don't even see often even in the adult care system.
At a national level, patient safety has been on the radar for about 15 years, and there have been a series of studies at the Institute of Medicine. I was involved in the final study on diagnosis, and diagnosis is just as important as treatment. It sets up what's done to patients. The study found that every American is likely to experience a misdiagnosis in their lifetime, often with severe consequences.
One of the big trends in the last couple of years has been toward larger practices, toward big organizations that control multiple delivery points in the system, hospitals, doctors, imaging centers, labs, and put it all together. The question is, should we adopt a more regulatory approach? Should we let markets work out? If markets are going to work out, how do we structure those to make things successful? And so trying to get that right, I think, is a question worth billions of dollars over maybe tens or hundreds of billions of dollars over the next few years, and it's something that we really don't have a handle on right now that we need to get a better sense of how to deal with.
And my own work has involved clinical interventions and screening policies. One of the areas that I've been interested in for many years is screening for HIV. We began this work a long time ago when screening was based on targeted, risk-oriented policies. It turns out those didn't work very well. We did cost-effectiveness analyses over a number of years looking at screening in different situations and circumstances and for different people. And over time, these cost-effectiveness analyses were an important part of policies developed by the Center for Disease Control and Prevention, by the Department of Veterans Affairs, by the American College of Physicians, and by the U.S. Preventive Services Task Force. And it was nice to see over a long period how research findings can eventually make their way into how policy is developed in the United States.